Thank you, sir. Good afternoon, everyone. I'll give you a brief overview about what intervention radiology is. So basically in intervention radiology, we use minimally invasive techniques to diagnose and even treat pathologies. So all our interventions are pinhole procedures without any stitch or scar. The concept is to use image guidance to reach the area of interest using needles and catheters. And because of increasing horizons and applications of intervention radiology day to day, so it's important to create awareness among the medical fraternity about the applications of intervention radiology. So these are the applications covering both non-vascular and vascular interventions.
I would like to request audience also to maintain the silence, please. Thank you.
Hello. Yeah. These are the various non-vascular and vascular interventions, and I will give you example of each and every one. So this is an image showing a CT guided biopsy of a sub-centimeter lung nodule. This was a patient who was operated for CA esophagus. On follow-up, there was detected a 9 mm nodule in the upper lobe. So with use of intervention radiology, we can even biopsy a lung nodule which is less than 1 centimeter precisely without any complication. And this is the needle within the traversing the lung, and we are taking samples from the lung nodule. This turned out to be positive for metastasis, and thus we can make early decision and improve the outcome of the patients. We can also do transpedicular vertebral body biopsy. This is a lytic lesion which is seen in the dorsal vertebral body. So here we are inserting a needle through the transpedicular route posteriorly and then sampling the lesions. Even the mediastinal lymph nodes can be biopsized percutaneously. Here this is an image which is showing a lymph node which is sitting right between aorta and lung. So we are introducing the needle through the anterior chest wall, preventing all the intermammary vessels so that bleeding doesn't occur. And here the biopsy is needle, we are sampling the lymph node. This turned out to be Cox tuberculosis. So these were the examples of percutaneous biopsies, but there are certain situations where we cannot do percutaneous biopsy, or rather percutaneous biopsies are very dangerous, like in cases of chronic liver disease where we want to biopsy the liver, there is presence of ascites. So because of presence of ascites, there is an increased risk of bleeding. So in this case we go transjugular route. So we puncture the jugular vein, we put a sheath into the jugular vein, we go into the superior vena cava, into the right atrium, and then into the IVC, and then into the hepatic vein. So this is an image, this is a schematic diagram which is showing that here we put a biopsy needle through the jugular vein into the superior vena cava, right atrium, and then we are going into the hepatic vein. And once we are into the hepatic vein, we wedge our catheter and then we take samples of the liver parenchyma, so that even if there is bleeding, that remains into the circulation and there is no hemoperitoneum. So in the same way, we can also do a transjugular kidney biopsy also in high risk patients. We can also do pain management. There are many pain management applications in intervention radiology. We can also do a CT guided epidural steroid block of any impinging exiting nerve root. So this is an image showing the same. Here we are putting a Chiba needle through the posterior aspect, and once we are into the epidural space of the exiting nerve root, we inject contrast to confirm the same. Here we can see the contrast which is surrounding the exiting nerve root, and once we confirm our position, we can inject steroid and anesthetic agent so that there is a pain relief. Even for cases of CA pancreas where there is intractable pain which are not improving on opioids, also we can do a celiac or a splanchnic nerve block. Here we are using a Chiba needle. We are placing both the needles just beside the abdominal aorta where the splanchnic and celiac plexuses are there, and then we inject absolute alcohol into that, about 10 cc in each needle, so that there is chemical alcohol neurolysis of the splanchnic and the celiac block, which is giving pain to the patient. So coming to percutaneous transhepatic biliary drainage, these are the procedures where we do in cases of obstructive jaundice. For example, in patients of cholangiocarcinoma, hilar cholangiocarcinoma, or CA pancreas where there is increased bilirubin, we want to bring down the bilirubin. So under ultrasound guidance, we puncture the dilated biliary duct, we pass on the wire, and I'll show you the example. So this is a cath lab image, we do it in cath lab. Under ultrasound guidance, we puncture the dilated duct, then we put a sheath inside it, then we take a cholangiogram. So this is a cholangiogram which is showing dilated hepatic ducts, but it is not flowing freely into the CPD because there was a hilar stricture. So we pass the hilar stricture. Here you can see this is the stricture part, and once we pass the stricture, we can easily put a stent across this. So here this is the image where we have put the stent across stricture, and now freely the bile is moving from the intrahepatic biliary radical into the CPD and then into the duodenum. So now the obstruction is gone, and so the bilirubin level will come down. Talking about applications of intervention radiology in oncology. So in oncology also, where there is early detection of tumor, like early detection of let's say hepatocellular carcinoma or liver mets, even lung malignancy or kidney malignancy, up to 5 centimeter of the lesion, if there is a solitary lesion, we can even treat it with intervention radiology. Here we put a small needle within the tumor and we ablate the entire tumor in single sitting. So the results are similar to that of surgery. The outcomes and success rates are similar to that of surgery. So the patients can avoid a large surgery, and this treatment can be done only with a single needle stick insertion. So talking about what are the options, we have radio frequency ablation available, then microwave ablation. Then talking about newer techniques, we have cryoablation, where we put a thick needle inside the tumor and then liquid nitrogen is given within the tumor so that the entire tumor freezes. We create a ice ball around the tumor so that all the cells die because of negative temperature. And even the latest is irreversible electroporation, where we use electrical field to cause cell membrane damage of the tumorous cell, and so the tumor cell dies. So this is just to give you an example how thick is needle. It is a 16 gauge needle. This is a radio frequency antenna. It's just like a hollow needle. We put a needle under ultrasound or CT guidance. Once we reach the, let's say this is a tumor, once we reach the periphery of tumor, we just push the plunger. This is the plunger, and once we push the plunger, the microtines will come out from the needle like an umbrella, and it will cover the entire tumor. And then we just connect it to the RF generator so that the heat is generated, and live we can see on ultrasound guidance the tumor getting burned. So this is a CT image where you can see 1.6 centimeter hepatocellular carcinoma in right lobe of liver. Here this is a CT image where the RF electrode is introduced, and these are the tines within the tumor, and this is post ablation. So we always ablate more 1 centimeter more as compared to the tumor size, because we want a negative tumor like a surgical margin. So this is a schematic diagram showing the same thing. If this is the tumor, we just reach the tumor and then push the plunger so that all the tines will cover the tumor, and we make sure that we cover more area as compared to tumor, and the entire thing is getting burned. We can also do, this is also a radio frequency ablation case of lung tumor. This was CA breast with a single solitary metastatic nodule in lung. This is the metastatic nodule which is sitting right besides the pericardium. Here we did a CT guided radio frequency ablation. Here the antenna is going into the lung nodule. This is a 3D image showing the same. And talking about osteoblastoma, now the treatment of it is a treatment of choice for osteoblastomas. Surgery is out of question. Everywhere it is radio frequency ablation. It is a simple half an hour percutaneous CT guided technique. If this is the osteoblastoma, this is the nidus of the osteoblastoma in femoral neck, and here the needle is being introduced into the nidus. Then we put the electrode. This is the bone biopsy needle, and once we reach the nidus, we put the electrode within it. We connect it to the generator, and here post procedure you can see charring. So it will burn the nidus. It will completely burn the nidus, and so the patient is pain free. This is the another image which is showing a osteoblastoma of the femoral shaft. Here again we are putting the needle within the nidus and then burning the lesion. So talking about vascular interventions, transarterial chemoembolization. So this is a widely accepted technique in hepatocellular carcinomas which are non-operable. It is the best palliative treatment available. This is a form of targeted chemotherapy. Here we puncture the femoral artery and go directly into the hepatic artery through the celiac trunk, and particularly into the arteries which are supplying the tumor. And once we are into the tumor supplying arteries, we inject the chemotherapy agent. The advantage is the maximum chemotherapy goes within the tumor, The normal liver cells are not exposed to chemotherapy. The systemic side effects are least as compared to systemic chemotherapy. And after the injection of chemotherapy, we also inject PVA particles. We block those arteries so that the tumor cell don't get enough blood supply and it undergoes ischemic necrosis.
So 5 minutes left.
Yeah. So this is a schematic diagram showing the same. Here it is the right lobe HCC and deposition of the chemotherapy on CT scan. Coming to embolization, we basically control, it is basically control of bleeding. It can be either uterine artery embolization, bronchial artery or a GI bleed. Talking about uterine artery embolization, any cases of uterine fibroids or adenomyosis who do not want to undergo any hysterectomy, they have an option of uterine artery embolization. They can preserve the uterus, no need of hysterectomy. It has a very high success rate. We basically puncture the femoral artery, go in left and right uterine artery, and we inject PVA particles so that the abnormal vasculature is cut off. The uterine fibroid undergoes complete necrosis and there is immediate stoppage of bleeding. So this is a case of uterine AVM. You can see this is a Doppler image which is showing abnormal tuft of vessel. We went and did arterial embolization with glue, and this is the post-therapy image. This is a pre. We can see the Doppler image, and here the completely tuft of vessel is not seen. We can do it for same thing for uterine fibroid also. This is a large uterine fibroid which is showing hypertrophied vessels, and this is a pre and post image. This is a pre-uterine fibroid MRI, and post embolization after 3 months you can see the fibroid is completely necrosed. So you can basically preserve your uterus. Talking about bronchial artery embolization in cases of massive or recurrent hemoptysis, basically there will be a hypertrophied bronchial artery as compared to normal patient. Here we are selectively catheterize the bronchial artery. You can see the tortuous vessel of the in the right upper zone, and we inject PVA particles which are permanent embolic agent, and once we have embolized, basically the cause of bleeding is gone. And this was another case of Rasmussen's aneurysm. You can see there is a large cavity in the right upper lobe and there is an aneurysm which is impending to bleed. So this was also embolized. This is a right bronchial artery catheterization. You can see the aneurysm, and once we have embolized after PVA particles, the aneurysm is not filled up with contrast. This was another case of GI bleed where there is a ruptured hepatic hemangioma. Here you can see the angiogram which is showing the culprit. This is the round bleb of vessel which was bleeding. We are selectively into the artery which is supplying that. We injected PVA particles and we embolized it with coil, and now you can see that this part is not getting the supply anymore. This was a case of post-TKR. The patient had a hemarthrosis, so there was a large pseudoaneurysm which was arising from a genicular artery branch. So we did a coil embolization of the same. For GI aspects, postprandial pain is seen in celiac artery and SMA artery stenosis. This was a case of celiac artery stenosis which was treated with celiac artery stenting. You can see a tight stenosis at the origin of celiac artery, this is the lateral image. Here we are doing the balloon dilatation. You can see the waist, here is the stenosis, and then once we put a stent, we can see all the branches being opacified. This is a case of peripheral arterial disease. The patient had gangrene in right lower limb. The culprit was a long segment stenosis or thrombotic occlusion of the right superficial femoral artery. So we went ahead and this is an initial angiogram which is showing that the contrast is not passing from mid-thigh level downwards. So we put a wire across it. We did a balloon angioplasty just like coronary, and then we put a stent across it, and now you can see the contrast is smoothly filling all the arteries of the leg. Here also there was a stenosis in the distalmost part of the superficial femoral artery. We did only a balloon angioplasty, and after balloon angioplasty you can see now the artery is completely opened up. Again a case of subclavian stenosis. This was a subclavian artery thrombus or a thrombotic occlusion, and we did a stent placement across the stenosed part. I'll be fast. Talking about varicose veins, we have two options available for varicose veins. We can either do an endovascular laser treatment or a glue treatment. So this is the image which is showing drastic difference between a surgically managed varicose veins and endovascularly managed this varicose veins case. So basically it is a stitchless and scarless procedure. You can't even make out the patient has undergone. any treatment. So it is this pinhole access which we do, and then we put a laser fiber into the GSV, we ablate the entire length of GSV, and below knee varicosities are injected with foam sclerotherapy. We can also do this, I am doing a glue treatment of varicose veins. Yeah. Okay, fine. And I'll just take 5 minutes, is that fine? Yeah. This is a case of massive DVT. Even DVTs can cause gangrene. This is a case of venous gangrene case where there was a massive DVT. All proximal DVTs extending into common iliac or external iliac vein has to be treated with catheter-directed thrombolysis to save the limb. So here you can see this is a pre-treatment. This is a pre-gangrenous changes in the limb, and this is the photograph of the limb just 24 hours after treatment. So the limb is getting saved in this type of treatments. This is a case of venous malformation into a left tonsillar fossa. This was a female having a hemangioma. We just did a single session of sclerotherapy injection percutaneous orally, and after 10 days this was the follow-up. You can't see the venous malformation. And talking about thyroid nodules, all non-cancerous thyroid nodule now have an option of microwave ablation, where we just stick in a needle and just ablate the nodule, and after 3 months you can see a drastic change. This is a pre and post image. You can see a swelling here, and this is a post image. Post microwave ablation, the swelling is gone. So basically the entire thyroid nodule gets necrosed, and the size decreases and the swelling disappears. Even for pulmonary embolism, this was a massive PE case. We did a thrombectomy, mechanical thrombectomy and catheter-directed thrombolysis. We lysed the thrombus. This is a thrombus being aspirated through the catheter, and this is a pre and post image. Now you can see in post image all the arteries have opened up. And lastly, we have also done genicular artery embolization for pain management. Here we basically, to control the synovitis pain, we do genicular artery embolization. We go from the femoral root, we embolize the genicular artery, and the pain reduces. And even for varicocele, I think the videos won't work. Yeah, for varicocele embolization, no need to undergo treatment, because there is high chances of recurrence post-treatment, because they are not occluding the gonadal vein. So in endovascular management, we go from the femoral root into the left renal vein, into the gonadal vein, and we completely occlude the entire gonadal vein, so that the chances of recurrence are least. So take home points: pinhole procedures without any scars, minimal hospital stay, and minimal complication rates are the way to go. Thank you.